benefiting from health.
Yeah, it's interesting you say that. It's that idea of sick care. It's something that I've thought about hospitals in general for a long time. I mean, that's what they do. They get you healthy enough to get out, but they don't necessarily provide the resources for people to maintain that health status. And it's sort of like this revolving door. And if they were to actually be more invested in the community health needs assessments, and not just invested in terms of doing them to check off the list, but like you're saying, to really involve themselves as people, not as just organizations, but involve themselves in thinking about what they really need to do. I think that would improve their approach to shift it from sick care to well care, I guess, is what I'm thinking. And you know, I think that you will still have people within these organizations, you know, like say you were saying with Cleveland Clinic, which is extremely wealthy healthcare system, but people within those systems who will say, if we do this, we will lose money. You know, if we do this, how are we going to make sure that we keep our, you know, wards full of patients? And I think that, as you're saying, you know, we really need to kind of dig down and go back to how this whole thing started with the community doing the work, you know, the grassroots people. So, but right now, a lot of the discussion is really high level. So, you know, you're thinking about these, you know, academic health care, you know, medicine and so on, healthcare providers, policymakers, and all of these people who are really the ones in a lot of ways driving the larger conversation. But we really need to get other people involved. So, you know, like the grassroots, obviously, but also people who are from sort of outside the typical discussion. So, you know, you're a geographer, for example, and you have a different approach to this. And, you know, as a social worker, I have a completely different thought process about health equity. And so we have other different voices who have been thinking about this for a while, but haven't been part of the conversation. So how do you think that we can kind of pull those people in? Like, what strategies do we need to get them at the table to sit down with the more traditional people and really come up with more unique, more effective plans that can be, you know, immediately implemented and generate change?
I've been thinking about this for a long, long time. And I'm now in my third lap of life. You get 3 laps, 0 to 30, 30 to 60. And if you're lucky, you get 60 to 100. I will tell you that as I've thought about this, distributed leadership, and we think about transformational leadership, and our mind always goes to that top person in the organization, whoever that top person is. And they're the only one that we think about as being transformative or charismatic or a change agent. But actually in distributed leadership, community leadership, we have to really see the transformation of a group of leaders of which they're connected to other leaders. And that's where we've had the disparity. We have 2 really worlds. We have a poor world and a rich world. We're becoming so much more divided that there's precious little connection between that. So I'm going to give you a good example. In Pittsburgh, where I spent 30 years of my life, there's a health system that's an integrated health system, Highmark and Allegheny Health Network. And Highmark Health has really understood that the grassroots community leaders are the linchpin of their success. In that same community, we have the University of Pittsburgh Medical Center, which has a different approach and a different philosophy. So you really have 2 different approaches in a community. And what I found with the differences there, and I've worked with both, is that the Highmark group right now is really seeing their future as being as much as engaged in the health and well-being of their community. Now, they are an integrated health system, so there's some economic benefit from people being healthy, and they are the largest player in the market in the insurance business, but they have a whole different approach. And I feel that one thing that I'm seeing and working with them and working with some others around the country is we really just have to move toward a different way of measuring success. Mm-hmm. So if the economic design is the value of health, and if it's the value of equity and the economic development that comes from people that are healthier and wealthier, the community scoreboard looks very different than maybe the fiscal bottom line scoreboard. And some of these not-for-profits are 15 and $20 billion organizations that aren't struggling. So when you look at, we have a hospital system in Pittsburgh that has 22 billion in revenue. And we're only a city of 300,000 people. We're probably the smallest city in the world with a healthcare organization that has 22 billion in revenue. And that healthcare organization has 90,000 employees and it has a very good bottom line. So do we really need that organization's bottom line to be healthier? Or do we really need the underserved of Pittsburgh to be healthier? And then here's the big finish. What's the value of a healthier Pittsburgh with maternal and child death rates as high as third world countries? There's 2 Pittsburghs, there's 2 every city, there's 2 Kansas cities. And so what I want to do is have people start to understand that what we're scoring, what we're counting is the value of lives and the economic value, and translate that and monetize that actually, and say, well, does it matter if you have 4 billion in cash reserves? What's the cost of that? What has been the cost of healthcare having a multi-trillion-dollar war chest? What's been the cost? Who's paid for that? Well, I believe it's been the underserved populations not getting the care that they've needed. In a sense, they've monetized poor health, especially in high death rates and in and there's so many just moral failures in terms of the health status of certain communities. And it's reflected sometimes in a misalignment of what those goals should have been. Mm-hmm. So I want to hold my friends accountable, but I also want to say that my friends in Pittsburgh at Highmark seem to be in the right direction by going in the direction of their communities and the grassroots folks, and not so much on the direction of perhaps their board and their constituencies.
So, I remember doing an interview once it was for a community organizing class that I took, but I did an interview with a social worker who is at a clinic that serves an underserved population in Boston, in Jamaica Plain. And, I remember mentioning at one point, I said, oh, the healthcare system is broken. And she said, it's not broken, it's functioning exactly how it was designed to function. And that's something that I've kind of carried around in the years since I spoke with her. But I want to sort of throw something at you. So let's say we kind of toss some bombs, as like we macro social workers are trained to do, is throw bombs at everything. Let's say we toss some bombs into American healthcare, we blow it up, we make a system that's more inclusive, more, I guess, to use your word, more moral. 10 years later, what do we look like? If we implement economic design thinking, a more moral approach to healthcare, like what do we look like?
Well, I think you can look a lot like other countries. And one of the problems we have in our current discourse is you can't talk about other countries. I remember during the last couple of years, if you've ever heard about Europe, it's always, well, we don't want to be like Europe. Like that would be the worst thing ever. Or we can't be like Canada. Well, well, that would be the worst thing ever. I think that if you look at other countries, they have a different value proposition for health. Health is a public right. Mm-hmm. Health is a public good. Why do we have the most expensive healthcare system in the world? About a third of all healthcare spending in the world is spent by our country with 4% of the population, and we have the worst outcomes. Yeah. So if we have the worst outcomes for spending 10 times more, it does lead to a question of, is this good? And is it right? And would we look at other models? So when people say, well, there's no hope, I can look at, I've worked in Canada, I've worked in other countries, and they're not perfect, but they have a system that has a different value proposition about health. And when you look at what's important in other countries, what's important is that we bring everybody to a certain health status that's important. Why do we have the worst health status in the world among 28 countries? Because we've let our system be exactly what it was supposed to be. A system that gave too much care to me, I'm the overserved, too little care to others, and the numbers don't hold. So I would say that looking at models from around the world is not a bad starting point. I don't think we have to go to the divine. I don't think we have to go to extraterrestrial places. I think we have the examples. And so health policy in America has to dramatically shift, but it doesn't have to shift beyond what other countries have successfully done.
Okay. So I guess one more, I think I have one more question for you. So you have a consulting firm that consults with a lot of these hospital and health systems. And I'm sure sometimes you have to tell them, like, you're doing this all wrong, or that I know that you want to do it this way, but I don't think this is the way that you should approach working with the community. How do you kind of square that circle, I guess?
Yeah.
The like sort of personal aspect and the more like company, I guess, Paul Umbach versus Trip Umbach. How do you kind of square that circle?
Well, it's hard. And I will tell you that coming from a social ministry background led me to always believe that being honest and truthful about my moral feelings was important. And as a consultant, I think I've pushed that envelope as far as I can. But just recently, I wrote an op-ed for Vanderbilt. And in the op-ed, I was really hard on government. And about disparities. My topic was the economic design of health disparities. And I was really hard on government. And I reread it and I said to myself, you know what? I've had about $100 million in revenue that's come from the healthcare delivery system for our consulting. And although I believe passionately that I'm a change agent in healthcare, I rewrote the op-ed, and I'll send it to everybody if you want it, or you can send it out to your followers here. And I pulled off the gloves and I said, this is not written through the voice of Trip Umbach, the company. This is really what Paul Umbach believes. And it was harsh, but also harsh in some ways on what I've been doing. One of the things we did for the Boston Teaching Hospitals years ago was we wrote an economic impact study that you can also find. And it talked about all the economic and social benefit of all those hospitals. And I look at that sometimes and I think to myself, I was paid to write a story of all the great things that Boston hospitals do, including Children's and Beth Israel and Mass General. And am I really part of the problem? You know, did I write a story that really overly promoted all the good they did and kind of swept under the carpet some of the sins that are in place? So it is hard. And I think what I have found is, as I've gotten to this point in my career, is that I have to be a voice for change. And often that voice for change will hurt the feelings of my clients. But in doing so, I've really achieved something much greater than maybe just getting paid to do a study or write a report. I think we've done so. And I think each person has to make that commitment. Each person has to say, what can I do at this stage? So, for example, this is being recorded. This video is going to go out. Some CEO at some hospital in Boston or Pittsburgh or somewhere in the country might look at this and say, we will never hire that crazy Paul Umbach again. And I have to be okay with that because it's what I really believe.
I think that's a really important thing that a lot of us have to carry with us as we go through this, is there's sort of like multiple masters that we serve. Yeah. And that we have to decide in this sort of fight to reach health equity, which master is most important to us. And, you know, I think that people in different fields will have different approaches to that. Yeah. And so, you know, as we kind of go along in this process and try to talk to more diverse audiences about plans to reach health equity, I think that, you know, that this kind of aspect of economic design thinking sort of, I think you should kind of spread it around more because, you know, I would love to have more materials from you and so that we can share with other people. But it's sort of like pulling all the different levers, like whatever lever you can pull to get this thing done. And I think there's a lot of people in our audience and in the world of health equity in general that really are looking to just kind of like pull whatever lever is necessary to get this done. Right. And so I think that, you know, this is a really critical time, and especially a critical time to bring in people like you, like other voices who have been thinking about this, but from a different perspective. And you know, I actually have something interesting. So a lot of these hospitals now in Boston actually are creating like community health departments and creating, you know, diversity and inclusion departments. And, you know, and now talking to you about some of the work that you did with them, I'm thinking, oh, maybe it came out of, you know, it came out of those kind of reports saying that they're not doing enough. But it's sort of like, it's still like, how much of it is because they want to do this and how much of it is because they feel like they should be doing this?
I think there is a change, and I think there's a change in all of us. I know I'm grieving today as I came into this interview for the young 20-year-old that was shot in Minnesota today for having an air freshener. And I just want to go and buy 1,000 air fresheners, and I want to put them all over my car. And I want to use that as a symbol. And maybe everybody watching will get an air freshener and say, we need to have that be a symbol. We need a symbol. We need a voice. We need to tell that story of pain and anger that I have. And I think a lot of people have, that certain lives aren't valued. And I feel that there's enough building up in the human side of each of us, not just the institutional side, that's starting to say we're going to be different. And I think one thing that's helping me is that when I was a young, white, poor consultant, when I was in my 20s, I was allowed to be on stage. And it's okay for me at my age not to be on stage. I can't go to the community rallies like I did. I'm not perceived as the solution. I might even be, in my look, the problem. Well, I think we talked about that before.
Yeah.
And I think it really relies, especially for those that are privileged, to be able to admit to that and say, I'm going to be better putting other people on stage. And I had a very dear friend in Pittsburgh named Teddy, and he was homeless and he lived in Market Square, and I lived in Market Square too. And I was going to write a book called Teddy and Me to talk about health disparities and about race and about relationship and about love and about friendship. And every time I tried to get the book published or talk to people about the book, people thought I was using Teddy's poverty and the fact that Teddy was in a wheelchair, and Teddy's a, 65-year-old African-American man who looks a lot like Morgan Freeman. And I couldn't tell Teddy's story. So I gave the story of Teddy and Paul to Teddy. Mm-hmm. And by giving the story to Teddy, that was the best I could do, is say, you have to tell this story. Mm-hmm. And I think that transferring our stories from experts to people that live in the situation will have the most to do with me getting off stage. Yes. And so I'm almost welcoming cancel culture. I want to be canceled so I can really plant seeds in the next generation. And that's a deep, deep thing. And I think that any white, rich person watching this, I hope you'll ask yourself that same question. Are we really the people that can drive this? Or do we have to get out of the way and let other people drive this and encourage that?
Mm-hmm. Yeah, it's interesting that you talk about that situation, because I remember one of the first things that we learned in my community organizing class is that, you step back. You are never the person on, like you say, on stage. You're never the person talking to the press. You are always behind the community, because otherwise you will be seen as an expert. You have all these letters behind your name, and they will, see you as the one who's driving things. And I think that we have to remember in doing this that a lot of us have a bunch of letters behind our names, and so we read as experts, but we have to remember to think about the community, because ultimately these policies and these practices that are going to come out of these efforts are coming from the community. And we have to know what the community wants, because we may assume they want or need something that has nothing to do with what is actually important to them. I found that in doing community-based research, that came in with one thing and they were like, we don't care about that thing. This is what we're really interested in. And I think it's difficult for people to relinquish that power. Yeah. And I think that's kind of one of the problems that we're going to confront eventually, is that we've got two different discussions going. We've got the community discussion going, and then we've got the experts talking about this, and those don't meet.
No, they don't. Yeah. And I think people ask me a lot. I'm going to give you more information on economic design thinking. People ask me about it. I say it's really that the currency of heaven is different. Mm-hmm. It's that we're dealing with currency based in love, and love actually is the only thing that can kill fear. So if you're fearful, love is the only thing that can snuff out fear. So much of what we deal with in this currency is that we have a monetary currency that's rooted in fear. Mm-hmm. Fear of I'm going to lose, fear I'm going to lose it, fear that I'll be poor. And love actually conquers that. But how do we do that? Well, I think the way we do that is we allow the currency of relationships to be bigger than the currency of monetary concern. And so I know this is very philosophical, but really allowing the movement to show that there is economic return for all. Mm-hmm. Mm-hmm. By addressing the social determinants, or by creating a more equitable society. That I did some back of the envelope economic, I'm an economist, geographer, and I said that we could have a $3 trillion bigger GNP if we got just to the average health status of other countries. So if we just became the average health status country, not the worst, but average, we'd have $3 trillion. Now the magic is, if you could sprinkle that 3 trillion back to the people that have now gotten healthier, mm-hmm. especially those that are underserved and those from racial and ethnic disparities, now you've really done it. You've put the dollars. But unfortunately, our system's not built for that. $3 trillion more in our GNP goes to the top 2% who are the healthiest. Yeah. So that's our challenge. Get healthy, get wealthy, and distribute the health and wealth. And that's what I'm at the beginning of a journey. So I have a 30-year journey that I'm going to, my final lap around the track here. And I need young people like you, Serena, and others to join that, because it's not going to be my generation. Baby boomers like me, I'm sorry, they're not. I wouldn't bet on that horse. And maybe we can only bet on the youngest kids. Maybe my grandkids are the ones we have to bet on. But we got to bet on some horse here that's going to get us through this. And I really pray that that everybody watching this is motivated to be part of that fundamental change that's necessary in changing health into wealth, but then redistributing the health and the wealth where it really needs to be, and stop this disparity. And that's what I've seen in 35 years of work. Is actually, I feel bad sometimes. I put my whole life into community health work, and it's gotten worse. Mm. And it's hard. So we have to do it differently, because you're right. I love your quote that we actually have a system that works exactly how it's designed to work, to make us unhealthy and to make us more disparate and more fearful. So let's break it.
Yeah, well, I think that that's sort of what we should be bringing from this, right? It's like we have to break the system and do something new. And it doesn't have to be an immediate fracture, you know, we step by step. You know, I have a mentor who kind of calls it, we don't have a Trojan horse, we got to have Trojan mice. Right?
Yeah.
You know, a little bit at a time, changing a little bit at a time. And so I think that in terms of reaching health equity, that's what we're going to have to do. We're going to have to make little changes at a time, because we're going to always be fighting a system that wants to, you know, that's inert, wants to stay like it is. And so
yeah,
I think that the, you know, sort of bringing these ideas of economic design thinking, pulling all the different levers we can, is a valuable approach to the conceiving of how are we going to do this. So I'd like to really thank you for coming and bringing an excellent perspective on health equity and thinking more broadly about it, and not just sort of alleviating health disparities, but really creating a culture of health and a culture of wellness. And that we have to remember that in the process of doing this, we always have to be thinking about the people. Right?
Yeah. Well, it's all about doing, and there's a moral problem with public health researchers when we keep measuring. I walk 1 mile from my house, and people live 15 years less, and I can walk that mile and tell you all about all the data points. I can tell you which block I cross, and now life expectancy goes down by X number of years. I could do a metric on how many steps per year. If I don't do anything about it, if I don't stop along that way in that walk and actually do something, then it's really on me as a researcher that I've understood the problem, but I've never done anything about it. I think that's a lot for us to deal with. Yeah. I think we need to know less about the issues. We need to do more about them. So I want to welcome anybody on the coalition that looks at data to ask yourself the question the next time you're looking at disparity data, and to say, can I live with that, knowing that? Is this really even right to measure change and not doing anything about it? So that's what I want to leave people with.
I think you've really, in a lot of ways, encapsulated what we want to do at P-TECH, actually, is stop describing and start doing. And you know, we're in the process of launching our research agenda and doing exactly that, looking at people who want to take the data and do, instead of creating more data. Like you said, we have a lot. We know stuff is wrong. We know it's functioning like it should be, but we want to change the way it works. And so I think that that's probably what we need to take from this. And I'm hoping that all of our audience is going to process this and try to find a way to integrate it into their work. So thank you again, Paul, for coming and sharing your vast expertise. And we will be having another webinar, and if you go to ptechhealth.org/events, you'll find more information about what's coming up. So thank you, audience. Thank you, Paul, and we will see you next time.
Thank you so much. It's been a real pleasure.
Bye.
Bye.